Hello and welcome back to OT Over Easy. My name is Becca and today we are continuing with our splinting series with part 2. Don't check the dates to see when I posted part 1. Don't do that. I've been busy, okay? The important thing is that we're here now and we're ready to talk about nerve-related splints. Specifically, we're going to be looking at peripheral nerve injuries, so your radial, your median, and your ulnar nerve. As always, this is not going to be a comprehensive video of every single kind of splint that could be relevant, but just to give you an overview when you're studying for an OT exam, what are the most common ones that they want you to know about. So let's crack on. So let's start with our radial nerve. The main splint that you are going to want to know about for radial nerve is going to be a radial nerve palsy splint. It is a functional based splint. And to think about what it does, we want to first think about what does the radial nerve do? If you think back to your anatomy courses, your radial nerve primarily is involved in wrist extension and finger extension. So if your radial nerve is not working, we have what's called wrist drop. Depending on the severity of the injury, they might have some wrist motion, but not very good finger motion. But generally speaking, the wrist and the fingers not extending is the deficit that we're looking at. So to counter that, we want a splint that is going to hold the wrist either in neutral or maybe slight extension and extend the fingers for them. Now this can look a lot of different ways. It can be custom fabricated, it can be bought over the counter, it can be a low profile, flat one, kind of like this. It could have huge outriggers with big, long cables on it, but largely the purpose and function is the same. If you need a review of terms like functional splint, refer back to part 1 of this video series. But because this is a functional splint, we're not expecting it to correct any deformities or help the nerve heal faster or anything like that. Its purpose is solely to help the patient be able to function better while they are awaiting the recovery of that nerve. So this is a dynamic splint. On my particular example here, my fingers have an elastic band that I can stretch against, right? Because in a radial nerve injury, assuming the median and the ulnar nerves are fine, they should still be able to bend their fingers, just not actively extend those MCPs. So it's a dynamic piece, so I can still make a fist, I can still grab things, but to help me release when I might not be able to on my own, the elastic or dynamic portion of this splint is going to do that for me. Note that it only needs to support the MCPs because your PIPs and your DIP joints, those are not extended by radial nerve innervated muscles. Those are innervated by your lumbricals and your interossei. So they can still probably extend the tips of their fingers just fine. It's only the MCPs that you have to support. So for a radial nerve palsy, you want a radial nerve palsy splint that is purely functional, just to help with the wrist and the finger extension. If they are at risk of developing a contracture, you may also need to give them a supportive splint, especially at nighttime when they're sleeping, just to help try to counteract that positioning, stretch those tissues out, prevent those contractures from forming. That is probably going to look something like this. Just a nice resting hand splint. My wrist is neutral to maybe in a little bit of extension. I have a little bit of a bend in my MCPs. My IPs are largely extended, maybe just a little bit of a curve. My thumb is in a nice comfortable position with a good bit of support for the web space there. Again, the purpose of this is just a static splint. So this is not a functional splint. It's not helping me function, but it is going to help me, especially when I'm asleep and not able to control what I'm doing, help keep me out of that flexed position that if I'm in that for too long, again, waiting for that nerve to return, could develop a contracture. I have some patients that I don't do this with, or I don't do it for very long because they are so diligent about their stretching, or they have good enough wrist radial nerve function that maybe they have a little bit of wrist motion and they're able to keep those tissues nice and loose with their own efforts, in which case that's totally fine. But if for some reason someone won't be able to do that or is going to have trouble doing that, you can give them a resting splint as well. And again, even with the functional nerve splint, just because someone has a radial nerve palsy doesn't mean that you absolutely 100% must give them a dynamic splint, must give them a functional splint, and they must use it. It's totally, you know, patient preference. If they feel like they need it or it's going to be helpful to them, yeah, go for it. But I definitely have had some patients that, you know, we've talked about something like that, and they're like, you know what, I'm going to be perfectly honest with you, I'm never going to wear something like that. And I go, you know what, fair enough, we won't worry about it. A splint is only helpful if somebody's actually going to wear it. So these are all options, right? But obviously you take your patients person by person, find out what their needs are, and go from there. So let's talk median nerve next. Real quick, let's review where that median nerve runs. So it's going to come anterior in the elbow, right? Course down, and also be anterior in the wrist. One of the most common median nerve dysfunctions that you're going to hear about either in your practice or when you're studying for the exam is going to be carpal tunnel, which is impingement of the nerve as it courses through the carpal tunnel right about here in your wrist. Typically, a large contributing factor to having carpal tunnel issues is sleeping with the wrist flexed. A lot of people do it. A lot of us like to curl up nice and snug like this, but spending several hours a night or day in this position, you can imagine if that nerve is coursing here, being like this, that nerve is getting squashed for several hours at a time. So for a lot of carpal tunnel patients, you are going to want to put them in a splint that is going to prevent them from getting into this position. It might look something like this. I can't get into this one because it was made for someone smaller than me, but that there would be the thumb hole, and it's going to hold the wrist in neutral. Now, it used to be that they wanted to hold the wrist in a little bit of extension was the thought process for a long time. So you might see that in some older textbooks, but now we have kind of come around on that, and really we want the wrist to be pretty close to neutral, because if you're going into extension, then you're kind of putting stretch on the nerve. So if you're coming forward, you're compressing it. If you're coming backwards, you're stretching it. And we don't want to stretch it either. So generally you want it pretty much close to neutral. Just like our radial nerve palsy functional splint, they can be custom made, or they can be bought over the counter. Generally, for my carpal tunnel folks, I recommend an over-the-counter brace just because they tend to be a little more comfortable. They've got a little more cushioning, things like that, versus the hard plastic custom made. And because they're sleeping in it, you want it to be as comfortable as you can. And again, because the purpose of it is just to prevent them from getting into that full flexion, it doesn't have to fit them super, super snug. It doesn't have to contour particularly well to them. It just has to prevent them from getting here. So any wrist brace that stops this is what you're looking for. Sometimes it'll be called a wrist cock-up brace. If it goes all the way around, it could be called a circumferential wrist brace. The name doesn't matter so much, again, just so long as you understand it is a wrist brace that blocks that full flexion. Okay, so let's move on to a median nerve palsy. So again, like our radial nerve palsy, we had to think about what does the radial nerve innervate? What is that lack of function going to look like? And so in the hand for the median nerve, one of the big things that you're going to notice when that median nerve is not working right is an inability to oppose the thumb. So opposition is bringing that thumb across in order to touch to your fingertips. That opposition is going to be lost. And so if you want a brace to help with that, you're going to use what's called an opponent's brace. So it's going to look like a little something like this. And again, it may not look exactly like this, but the purpose is to hold that thumb a little bit in opposition. So I'm not way forward or across like this. because you can imagine that's going to get in people's way too, but just a little bit. That's going to help hold me just enough that I can get across to those fingertips, as opposed to if I'm stuck way back here and I can't bring that thumb forward, I'm not going to be able to move across. So again, functional brace, we're not helping to correct a deformity per se. We're not helping to heal the nerve. We're just allowing for better function while we wait for the nerve to heal. This kind of brace, like I called it before, an opponent's brace. This particular style could also be called a thumb spica, a hand-based thumb spica. If you see that term thrown around, a thumb spica just means it is a brace for the upper extremity that includes support to the thumb. So this is going to support when your opponent's pollicis is out. But if we think about some of the other muscles in the hand that are innervated by that median nerve, we also have our first two lumbricals. And we're going to loop in the ulnar nerve here as well, because the median nerve does these two lumbricals and the ulnar nerve does these two lumbricals and your interossei. Now here's a little insider knowledge from a hand therapist for you. I'm pretty sure that when I was in school, I was taught that the lumbricals are primarily responsible for flexing the MCPs and extending the PIPs and the DIPs, and that your interossei were primarily responsible for the abduction and adduction of the fingers. But in reality, the lumbricals actually really don't do much for motion. This motion, they do assist with it, but this motion is still primarily the interossei. Your lumbricals largely are more for proprioception purposes. They do very little for motion. So actually, it's mostly the interossei that are doing this. So you can imagine if your ulnar nerve is not functioning and not able to perform this motion, then the hand is going to assume a position like this, which we call a claw hand, right? So if the function of those muscles is to bend the MCPs and extend the PIPs and the DIPs, then if it's not working, the hand is going to fall into the opposite. So MCP extension or hyperextension even, and PIP, DIP flexion. So if we want a brace that is going to counter that, we want it to bend those MCPs for us. So that is going to may look like this. Again, like all of these, it can look different to this, but again, don't think about what it looks like. Think about what its purpose is. This particular one is going to go on something like this to block me from having that MCP hyperextension. So again, probably they'll still be able to flex those fingers okay. We just want to stop them from getting into that hyperextended position. So this is an anti-claw orthosis. This is one that encircles all 4 digits, which most commonly is going to be for folks that have both a median and an ulnar nerve injury. If it is just the ulnar nerve without the median nerve, it might look something more like this, where it's going to block only the small finger and the ring finger. So it's left my long and my index finger free. And if it's if it's ulnar nerve only, remember my median nerve is still working. My median nerve does the lumbricals for these two, and even though lumbricals don't help much with motion, they might help enough that they're going to help kick on to prevent that clawing position. So in which case I only am protecting these 2 fingers from getting into the claw. But for that combined median and ulnar nerve injury, you're going to want all 4 of them included if all 4 fingers are going into that claw position. Sometimes these are referred to as figure of 8 braces, which you can kind of see why that might be, but anti-claw orthoses with a dual purpose, partly to help prevent contracture, right? If you're like this all the time, eventually those joints are, the soft tissues around the joints rather, may contract to get someone stuck in this position. So you want to prevent that. But also, again, for function, really difficult to do anything when your fingers are back like this. But if you can bring them forward, it actually allows you a little bit better use of the hand. So those are the main median nerve conditions you want to be aware of. Your carpal tunnel, you're going to have that wrist brace preventing you from coming out here. Your opponent's brace, if needed, to help hold that thumb in opposition, and or a figure 8 anti-claw brace to help with this deformity, if it's present. So when we're looking at ulnar nerve, we just talked a little bit about it with that anti-claw orthosis. That could potentially be something that is needed if they have an ulnar nerve lesion. But the other main condition that you want to be aware of for your OT exam is going to be cubital tunnel syndrome. So if we take a step back, think about the anatomy of that ulnar nerve and where it runs. That ulnar nerve is going to come down posterior to your medial epicondyle, right? And then course up through the forearm. So your cubital tunnel is right in here. So just like with our median nerve and our carpal tunnel getting impinged here, for your ulnar nerve, your cubital tunnel, the nerve might be on too much stretch here. Again, just like with the median nerve, often sleeping is the main culprit. Once again, we're in this position, so not only is that wrist flexed, but so is that elbow, and so that nerve, as it comes around the backside, there is in a lot of tension for many, many hours. So if we're looking at a nighttime brace for the ulnar nerve, for that cubital tunnel, you want something that is going to, again, prevent you from getting into this flexed position. And that might look a little something like this. So this is a thermoplastic version of this brace. Once again, you can get a custom one, you can get an over-the-counter one, or have your patient order one online that's nice and soft. But again, once more, don't worry about what it looks like, think about what its purpose is. Our purpose here is to prevent us from getting into that hyper-flexed position. So here, it's on the anterior surface of my arm, stopping me from bending. A lot of the time, I will not make a hard plastic version of this, just like with my carpal tunnel brace. Hard plastic, really uncomfortable to sleep in. It's going to be far more comfortable if they can get something soft. But even then, when compared to the carpal tunnel brace, because with carpal tunnel, your wrist is here, which is still largely a very functional, usable position, this is really unwieldy. I mean, you can imagine getting up in the middle of the night, trying to use the bathroom, having your arms stuck like this is, it's no fun. And so even more so than a plastic version of the carpal tunnel brace, people will rarely tolerate this. An alternative trick you can use that might be a little more tolerable is to just instruct them to take a towel, just wrap up a towel and wind that around the arm, and that will be a lot softer, a lot more comfortable, and gonna have a little bit more give. So because we're just trying to stop this position, it doesn't matter if there's some give in it, right? Generally speaking, if you at least don't go past 90 degrees, that's good. So if you sleep like this, it's a lot better for that nerve than sleeping like this. So if you wrap in a towel and it allows you to do this, that's okay. The only thing we don't want is to be here. But when thinking about an exam, the most important thing that you want to be looking out for is if they're asking you about cubital tunnel and what you might be able to do treatment-wise for cubital tunnel with regards to a splint, it's going to be something to block flexion of the elbow while they're sleeping. And that's it for the peripheral nerves. I've said it several times in this video, but I will say it one more. Don't get hooked up exactly on how the splint looks, because a lot of the time they're going to be looking different. Think about what it's for. What is the purpose? and that is what is going to guide you to the answer an exam question is looking for. But I'm a visual learner too, so I hope that just getting to see a couple of examples helps to clarify some things in your mind. If you have any other questions about any of the splints we talked about in this video, or any of the conditions we talked about in this video, feel free to put them in the comments below. Otherwise, I've got at least 2 more videos planned for talking about different kinds of splints. Again, the most common ones that you're going to want to understand for a generalist OT entry-level exam. Those should be coming out in the next month or 2, so keep an eye out for that. But otherwise, I hope that this made understanding splints a little more easy. Happy studying!